behalf of the Toronto Adult Congenital Heart Disease Program, I welcome you to the International Toronto ACHD Rounds. And it's my great pleasure to introduce to you Dr. Ann Bassett, who is an expert and a giant in the field of 22q11 deletion syndrome. Dr. Ann Bassett is professor of the University of Toronto, Department of Psychiatry, director of the Clinical Genetic Research Program, Center for Addiction and Mental Health, and the director of the Dalglish Family 22q Clinic for Adults at the Peter Mankey Cardiac Center. And last but not least, she had the lead of the recently published 22q11 practice recommendation for management adults with 22q11 deletion syndrome. So it's a great pleasure to welcome you and to listen to your talk entitled, "Why Do These Patients Benefit from Special Services?" Welcome.
Thank you so much, Erwin. It's a real honor to be part of this group of talks and seminars. And it's what I'm going to concentrate on today is I'm really going to focus on how 22q is important and why it's useful clinically to make a diagnosis, make a genetic diagnosis for cardiologists, particularly those who care for adults with congenital cardiac disease. So first, just a little refresher about what we're talking about. The 22q11.2 deletion region, rather complex region of the human genome, but I'm going to focus in on the what's the most important aspects of this condition. So historically, 22q11.2 deletions were diagnosed using FISH, fluorescence in situ hybridization. This is a targeted test, and the blue vertical line on this with the top where it says FISH probes N25 and TOPL1, these still used today. It's a targeted test, but what you'll see in the bottom bars that describe the different sorts of deletions that usually occur in humans. The top one there being the typical, what's called 3 megabase, it's really 2.5 million base pairs length of deletion. About 90% are that length. The FISH test will pick that up. It will also pick up nested proximal deletions, the A to B and A to C. And where those letters, what those letters mean are the green boxes at the top of this figure. They're low copy repeat sequences or sequences of DNA that are so similar one to another that during either spermatogenesis or oogenesis, so during gamete formation, this deletion can occur, and it occurs in a single egg or a single sperm. The human genome is set up for this kind of error to occur, and you'll be very surprised to know how often this actually occurs. This is why the structure of the human genome in this rather complex region is why you get this occurrence, the 22q11.2 deletion, across the world, all ethnic backgrounds, because this complex region is set up with these low copy repeat sequences so that these sorts of errors can occur. There are also distal deletions, which you'll see nested in there, the B to D and the C to D, so that these are ones that occur and recur in unrelated families between those one's on the right-hand side, the green boxes on the right-hand side, the low copy repeat sequences. So this is something that occurs to young couples. There's no maternal or paternal age effect here for this occurrence. It's not like Down syndrome or triple X or anything like that. So the trisomies where it's more common in older women. It's not like a point mutation that's more common in older men. This is an occurrence that is a natural error in humans because of these low copy repeat sequences. Why it occurs in only some eggs or some sperm. That's and to some couples is certainly something that we're really trying to understand. So clinical genetic testing has been available since 1994. The current standard test is a microarray, which is a genome-wide assessment of copy numbers. So this is deletions, duplications, so big paragraphs or even chapters of the genetic code that are either extra or missing. This is not a test that assesses for point mutations. There's also prenatal and non-invasive screening available. This is an under-recognized condition to this day, and there's a considerable diagnostic odyssey for many patients, even when they may have what would be considered standard features of this condition. It's less delayed. The diagnostic delay is less with congenital anomalies of the heart and the palate, but the variable expression is really against us for making a diagnosis. The number of features differs between individuals, the severity of each one of those features differs, and the pattern of those features changes with age. And they're both congenital and later onset features, multisystem, and that's what I'm going to talk to you about. So the health issues change over time. In the literature, you know, with all genetics, the focus is often on infants and children. So developmental delays, feeding difficulties, and of course the congenital anomalies like the congenital cardiac anomaly are the main focus in infants. And then in children, it's the speech delay, palatal problems, learning difficulties, often ascribed to the being on the bypass machine. But in this case, absolutely attributable to the 22q11.2 deletion. So there are also attentional, emotional, behavioral issues that start to arise in children. And then in adults, the focus is way more about the functioning. How are they going to do? What are they going to do when they grow up? And still, to some extent, the issues with speech, learning, for sure, is ever present as an issue in management. And then it's treatable psychiatric illness like schizophrenia, and the more common even than that is anxiety in this condition. And then there are what arise over time are treatable multi-system medical problems, and I'm going to show you what those are. So what we provide at our multidisciplinary clinic, which is the world's first clinic for adults with 22q, at the Toronto General Hospital, the Dalglish Family 22q Clinic, that we operate jointly with the ACHD Clinic, and particularly with Dr. Oxlin, and we do transition clinics with the Sick Kids 22q Clinic. We've seen over 450 adults with 22q, so we have the world's largest experience with patients with 22q. We provide both clinical care and research, both clinical and basic, especially genetic research through our clinic. We provide comprehensive assessments and family involvement and individualized care and long-term follow-up. So why is this important I'm going to try to convince you, I think it is, in adult congenital cardiac disease. So first of all, 22q accounts for a substantial proportion of patients with CHD. So the prevalence studies show this deletion in an estimated 1 in 2 individuals with interrupted aortic arch type B, 1 in 3 with truncosarteriosis, 1 in 8 to 10 with tetralogy of Fallot, and 1 in 10 to 20 with ventricular septal defects. This is replicated research, incontrovertible. It's not only the conotruncal anomalies. They are definitely the favored anomaly associated with 22q11.2 deletion, but all congenital cardiac diseases have been associated with this deletion. So what about the prevalence? So this is the most common microdeletion syndrome in humans associated with that deletion that I already showed you, previously known as DeGeorge or velocardiofacial syndromes. We're definitely focused on calling it 22q at this point. The previous names don't help you because it's the same genetic underpinning. But if you think that you're looking at a patient and you think that 22q is like DeGeorge syndrome, and in your head, those are very seriously affected babies who may die in infancy, that's not 22q, not at all. It's a hugely variable condition across the lifespan. It involves 1 in every 2,148 live births. So this is something that we study that we did based on newborn screening, looking at 30,000 heel prick results. And what we found is that the condition is in, or the deletion itself is in babies born to, tends to be younger mothers. The babies are smaller on average, so they're born sometimes with being small for gestational age. So the growth abnormalities are already present in some of these infants at birth. It's a new genetic change in over 90% of cases, which is because of the structure of the human genome. That is, there's no family history. There certainly may be a family history of congenital cardiac disease because congenital cardiac disease is so common in the general population, but there does not need to be. There's variable expression of all features, which I already mentioned, both the number and the severity, and involving multiple systems, and it remains under-recognized, as I mentioned. So the clinical genetic testing, people still do FISH, but you're going to miss the other types of deletion that do not involve the, particularly the TBX1 gene and other genes in the proximal region, if you don't do microarray. So just to give context to how prevalent this condition is, what I've put on here are familiar conditions that are, would be picked up through newborn screening programs. And what you can see is that the 22q11.2 deletion, if it were involved, which it is not in any newborn screening program on Earth, it's more common than many of the trisomies, not than Down syndrome, of course, but it's more common than congenital hypothyroidism. It's more common than cystic fibrosis. So just, you think about how much, is known about cystic fibrosis and how little is known, relatively speaking, about 22q. It's more common than that condition, way more common than phenylketonuria. So it's associated with premature mortality. So this is where we're going to see why it's important to have a genetic diagnosis in any individual, children and adults, with major congenital cardiac disease or even minor congenital cardiac disease. So what we did was we compared our patients with and without major congenital cardiac disease, and we looked at survival. And if I were showing on here the unaffected siblings, they go across just basically in a straight line at the top. But here what we're comparing, the orange bar on the right-hand side in this survival curve are those individuals with the 22q11.2 deletion, but with no major congenital cardiac disease. They may have BSD, ASD, but not tetralogy of Fallot, not truncosarteriosis, et cetera. And what you can see there is that the median age at death in our patient sample is in the 50s, in the early 50s for those without a major congenital cardiac disease. But with a major congenital cardiac disease, the median age at death is 37.3. And this has been pretty stable across the years that we've been studying individuals. What we then also went on and did was we compared the median age at death of our individuals where we knew they had a 22q11.2 deletion. So that's 37, there it is. And we compared to a sample of individuals with the same congenital cardiac disease, tetralogy of Fallot, but without the 22q11.2 deletion. And you see there, no 22q deletion, average age at death is 55. With the deletion, average age at death is 37. So that's highly statistically significant. The multi-system burden of this condition affects mortality within patients with congenital cardiac disease. That's a replicated finding now as well, by the way. So when we look at the hazard ratios for all-cause mortality within those 612 adults with tetralogy of Fallot, some of whom have 22q11.2 deletions, what we see is that the deletion itself is the most impactful risk factor. So accounting for pulmonary atresia, still the 22, which is much more prevalent in individuals with 22q and 1.2 deletions. It's about 1 in every 4 with tetralogy of Fallot have pulmonary atresia. So, but you account for that, still the deletion is having an impact on mortality. We accounted for the surgical era, because of course that's important with respect to mortality. We accounted for sex and age at ascertainment, and the deletion comes out at the top, the hazard ratio. It's 5-fold difference in mortality. So what are the causes of death within individuals with tetralogy of Fallot, and comparing those with the 22q11.2 deletion and those with other forms of tetralogy of Fallot, not the 22q11.2 deletion? And what we see is that, not really surprising, cardiovascular causes of death are significantly greater in those with 22q11.2 deletions compared to those without. So the others, they survive to die of other causes more often in those without a 22q11.2 deletion. And the most common cause of death, or one of the most common causes of death in our patients is sudden cardiac death. Heart failure also pretty common, and then some, with stroke, and we've had a patient die of cancer. So cardiovascular disease, very important in terms of cause of death, but more important in those with tetralogy of Fallot and dying at a younger age. So what are the other comorbid factors that are important in cardiovascular disease and management? So this is why we have our clinic. Multimorbidity in 22q is as burdensome as individuals in the general population who are in the 65 to 69-year-old age group. It's, if you have 22q and you age match, we compare it to a Stats Canada, so it's Statistics Canada general population, the odds ratio of having multimorbidity, and here very conservatively assessed at needing 5 or more medications. It was 18-fold different for those at in the same age group, so 25 to 44. So already in that very young adult age group, they have a major burden of multimorbidity. It's higher than those in the general population who are in the next group up, 45 to 64-year-olds, and as I said, about the same as those in the 65 to 69-year age group. And this held even when we excluded those on antipsychotic medications, known to have a higher burden of multimorbidity. So what's multimorbidity? What is it in this condition? Well, it includes treatable endocrinological conditions that are pretty important for cardiac care. Very high prevalence of hypothyroidism. So 1 in 4 develop hypothyroidism at a much younger age than in the general population, and its equal sex ratio, male to female, so very different than in the general population. There's also a high prevalence of hypocalcemia. So what can that do, hypocalcemia? That, cardiac-wise, I mean, it certainly can cause fatigue, which can be mistaken for cardiac disease. But it also can affect, obviously, increased risk for arrhythmias and lengthening the QR. So it's important also. This is due to relative hypoparathyroidism is also associated with hypomagnesemia and hypothyroidism. So you have to be looking at all of these metabolic and endocrine conditions. There's an elevated prevalence of obesity in adults with 22q, and again, this is even when we account for antipsychotics. This is apparent by early adulthood. So they start out kind of small, and if you see the pediatric population, children with Somebody's got a baby or a child, and they're babbling in the background here.
Erwin, can you mute those people, or Kristen? Can you mute the person who's talking?
Yep, I'm
Miriam,
going through them
please
right
mute.
now.
I'll try and talk over the top of that. So obesity is more common. These individuals with 22q start out kind of small, but they blossom, with very early on in adulthood. There are lots of reasons, obviously, for obesity, but this is part of the metabolic conditions that are associated with this condition, and it's apparent by early adulthood. There's also, we found an increased risk for type 2 diabetes in adults with 22q. The hemoglobin A1C significantly diverges from the norm, from the Canadian population norms. It's apparent by age 35. The median age at onset of type 2 diabetes in 22q is 32 compared to the population at age 50. So we're assessing for this at a much younger age in our patient population. And we know that the deletion imparts risk for developing type 2 diabetes, even when we account for other known risk factors like the obesity, the schizophrenia, antipsychotic use, sex, age, ethnicity, and family history. We accounted for all of those in our sample. We've more recently found that there's an elevated risk of hypertriglyceridemia in 22q, mild to moderate levels of hypertriglyceridemia. So, and it's extraordinary, really. 40% of our patients, and among those with 22q and hypertriglyceridemia, over 3/4 were under age 40. So it's again, and accounting for other factors involved in hypertriglyceridemia, which is shown on this slide. So there's the risk that's imparted by having the 22q deletion. It's at the top of the tree here, even when you account for male sex, body mass index, so obesity, non-European ethnicity, age, and antipsychotic medication. Something we published last year. We've most recently found, so this is just published by a wonderful medical student who works with me, Sabrina Cancellieri, has shown that obstructive sleep apnea is the risk for obstructive sleep apnea is also elevated in individuals with a 22q deletion. And again, using a multivariate logistic regression model, what we see is that when you account for other factors within the sleep apnea, so this is within individuals with 22q, those with and without the sleep apnea, what you see is that pediatric pharyngoplasty, so this is like 30 years after they had their palates repaired with a palatal flap, that imparts some additional risk on top of the deletion risk. Asthma is a risk factor, obviously, obesity a risk factor. So all of the regular risk factors are definitely in play for individuals with 22q. But the deletion kind of magnifies all of those effects. Again, obstructive sleep apnea, pretty important to consider for individuals with congenital cardiac disease. Then another wonderful medical student of mine who's now gone on to general internal medicine training here at the University of Toronto, Christina Blagojevic, what she found a couple of years ago, and I've got kind of two things going on here. So what she found looking at our spirometry parameters is that the deletion adversely affected those spirometry parameters over and above the effects of scoliosis. Now, again, just taking a step back, scoliosis is far more prevalent in individuals with 22q11.2 deletion syndrome form of congenital cardiac disease than in those without a 22q11.2 deletion. So it's kind of knock-on effects. So you've got scoliosis, and this is a previous publication working with individuals in the Netherlands who came over and helped us study this by looking at all of the chest x-rays of our patients. What he found was that 45% of individuals with 22q without any congenital cardiac disease had scoliosis. So it pretty well showed that scoliosis is not, in fact, caused by cardiac surgery, which was previously what was thought to be the case. And that was because the 22q11.2 deletion was not part of what anyone was looking at. Excuse me, in those studies, very similar to thinking that all of the developmental delays that were found in children with severe congenital cardiac disease were attributable to being on the bypass or having the cardiac surgery, when in fact, most of the effect was coming from individuals with 22q11.2 deletion and other syndromic forms of congenital cardiac disease. So what this result shows, looking at the spirometry parameters, is that in 22q, different from other individuals without 22q, there's evidence of both restrictive and obstructive mechanisms. So that means that some of that is actually treatable, treatable asthma. So probably worthwhile establishing the diagnosis of 22q, which is what Mike Gatsoulis wrote about in a companion article in this journal. So what about the multiple neuropsychiatric conditions that are relevant to cardiovascular disease and management? Well, they start right at birth and they continue on through life. The neuropsychiatric expression of 22q, again, is very variable from individual to individual, but what is on this slide are all the features that are relatively common and certainly more common in this condition than in other forms of congenital cardiac disease. So neonatal seizures, usually hypocalcemic, and the patients basically grow out of that. They're often started on some calcium supplements, maybe even calcitriol, but then they're taken off of that in childhood. Developmental delay and intellectual disabilities, there's a feature that lasts lifelong. Autism spectrum features and disorders in a minority of patients. Attention deficit disorder, quite common in children. They often grow out of that condition, but it can be effectively treated. Recurrent seizures and epilepsy. You might have had a neonatal seizure, probably you didn't, but in this condition, the way the brain is developed in the face of having this deletion in every cell is that there's a lowered seizure threshold. Both provoked and unprovoked seizures, and about 5% develop epilepsy. Mood and anxiety disorders are particularly common in this condition, schizophrenia and other psychotic disorders as well. And then as people age, neurodegenerative disorders, in particular Parkinson's disease at an early age at onset. So here's the relative risk having a 22q11.2 deletion and not for having intellectual disabilities. So 22q are the orange bars, the general population expectations are the blue bars. So intellectual disability is more common, but it's about 30%. The rest do not have intellectual disability. They're in the borderline to low average range, but still with significant learning difficulties. Borderline intellect, so that's the biggest group. So just above the rate of the IQ where you would get services, but enough to get to really affect functioning. Epilepsy, as I mentioned, 5%. Anxiety disorders about twice as common than in the general population, where it's very common as well. Schizophrenia is about 20 to 25 times more common than in the general population. And when we look just within our adults with 22q deletion forms of tetralogy of Fallot, 19% develop schizophrenia with a median age at onset of 21 years, which is right where you would expect it as for the general population. So it's garden variety schizophrenia, but it's certainly the thing that most parents are worried about with who have children with 22q. And then early onset Parkinson's disease is something that we discovered in our group, and we're actively studying as an association. So here we're showing, okay, what affects long-term outcome or adaptive functioning in 22q. And what we found is, not surprisingly, it's mainly mediated by the IQ, so whether or not the individual has learning difficulties and intellectual disability, and the psychotic illness, schizophrenia, which is a severe psychiatric illness. There was no significant effect of technology of flow or other congenital cardiac disease or repair on adaptive functioning once you had, within 22q, once you had accounted for the IQ and the schizophrenia, and even once you had accounted for the mood and anxiety disorders, again, as long as they're treated. There's a big range on the top left-hand side of the slide. You see a wide range of IQ within this condition, and what we're showing here is like the bell curve of IQ that's on average 30 points lower, and on the left-hand side are the parental IQ. So we did a study where we studied both parents, and we studied who were unaffected with 22q and their offspring with 22q, and there is a connection. There is an association, as there is in the general population. Your IQ is affected by your parents' IQ, intellectual functioning, but the deletion brings you down on average 30 points. But there's still a connection to the background effects of parental IQ in 22q. So what about management? You know, I hope I've convinced you already that it's important to make a diagnosis of this condition. And Erwin mentioned that we've just recently developed updated guidelines. So we started our original guidelines, the Pediatric International Clinical Practice Guidelines for 22q were published in 2011. And then the adult guidelines we first published in 2015. And just last month, finally, after 3 long years of effort, we've published both updated clinical practice guidelines for adults and for children in the official journal of the American College of Medical Geneticists, which is called Genetics in Medicine. And Erwin and colleagues were involved in the congenital cardiac disease recommendations. So what are we doing? Why is this important for care to make this genetic diagnosis? Well, the management does differ. First of all, you're doing targeted investigations and monitoring that you would never do for other individuals with congenital cardiac disease. You're watching the ionized calcium levels, the parathyroid hormone levels, especially at times of biological stress that includes during surgery and around surgery. You're monitoring the thyroid stimulating hormone levels. You're providing vitamin D and sometimes calcium supplements, but particularly vitamin D supplements. That's a standard recommendation for all individuals because the risk of hypocalcemia is so great in this condition. That's a standard recommendation. We're very interested in early diagnosis of treatable neuropsychiatric illness because that maximizes the chance of better outcome and helps medical care. If you treat the psychiatric illness, the patient is, no surprise, more likely to come to clinic and will do better overall in managing their cardiac disease. These patients have emotional storms or emotional outbursts that are particularly present with undertreated or untreated psychiatric illness. You have to, account for the roles of caffeine, fatigue, hypoxia that could be due to the obstructive sleep apnea or the congenital cardiac disease and hypocalcemia. But, if you treat the psychiatric disease, again, the overall management for these individuals is just better. For individual conditions, including congenital cardiac disease, it's standard of care, it's standard management. But the personalization for individuals with this condition includes appreciating the multi-system burden that they have and managing each of those other aspects of the multimorbidity and being aware of the doubled risk for any complication, any surgical perioperative complication. And we would now consider probably early pulmonary function testing, given the risk for asthma in this condition. We also, for these adults, like for a lot of patients in the congenital cardiac disease realm in adult congenital, we're involving the family and the caregivers in the care. These patients have particular challenges with keeping appointments, with adherence to recommendations, especially those with neuropsychiatric conditions or disabilities, and that's the vast majority of individuals. And that's what our multidisciplinary clinic is all about, is helping to do that. So it's also important because it's a growing population. With improved pediatric surgical outcomes and obstetrical care, there are more and more individuals born and living with 22q. Reproductive fitness is often unaffected in this condition, especially for women. There's only a modest impact, it seems, of serious congenital cardiac disease with respect to reproduction. There's different genetic counseling for individuals with this condition. About the associated psychiatric and medical conditions, so the anticipatory care issues, the 50-50 risk of transmission of the deletion at each conception is important to convey to individuals, but that you can't predict the severity at this point of the associated conditions. Assortative mating, very important to consider. What's brought in by the person's partner to individual risk for the offspring. Independence, the issue, everybody wants everybody to be independent, but often supportive families are incredibly important. And again, lifelong, we've got lots of families with 70 and 80-year-old parents still doing yeoman service for supporting their offspring, adult offspring with 22q, and enabling the provision of services that are required. And we have a fabulous social worker in our clinic that helps do that. There are also parenting issues, and disproportionate number of our individuals with 22q have had to have the help of the Children's Aid Society. Children may be adopted, or they're helped so much by grandparents, or actually brought up by grandparents. I mentioned before that prenatal testing and screening are available for the 22q11.2 microdeletion. So that's standard prenatal testing using microarray and amniocentesis or chorionic villus sampling, but also not in recent years. This is since about 2015, the availability has been increasing for non-invasive prenatal screening. It's not diagnostic testing, but it's pretty good at the screening level. So this is a blood test that now includes selected microdeletions, not just trisomies. And they certainly, the foremost one that they find, because it's the most common, is the 22q11.2 microdeletion with the cell-free DNA prenatal screening available. So this is a condition that exemplifies precision medicine. There are huge benefits of having a molecular diagnosis. So at the basic level, at the bottom of the triangle here, is the anticipatory care, including the vitamin D, the access to specialized clinics and better medical care, sense of belonging to a group. They're going on the internet now, and they're automatically into a group with others with 22q, and we have groups also for our patients through our clinic. So there are increased opportunities to optimize social and educational needs. There's better interaction with health professionals once the diagnosis is made. And in our observation, that includes more respect and attention. Oh my goodness, you have a piece missing on chromosome 22, makes a difference for an awful lot of people, including even government bureaucrats. So it's a platform for advocacy, for greater understanding and certainty, and it does provide a lot of hope for patients and their families, and a sense of purpose. And certainly for the poor parents, more appropriate expectations and less blaming, particularly of mothers. So just another area of emerging area of what we're examining with respect to personalized care and the other risks that may be imparted by this 22q11.2 deletion. This is work that we've done in the past couple of years with an undergraduate student, Adonis Ng, and with Erwin, is that there seems to be an increased risk of bacterial endocarditis in 22q, just to top everything else off, when compared to other individuals with tetralogy of Fallot who don't have the 22q deletion. So what's coming soon, what's on the horizon, a lot of genetic studies now using whole genome sequencing, and that improves coverage over the exome, and it allows you to assess other types of variation that I can tell you about if anybody's interested. What we have the hypothesis here, what we are often testing is that the deletion is acting as a magnifier of effects that are present elsewhere in the genome. So other variants, structural and sequence variation, that are going to help us understand variable expression within this condition and also in the general population. So it acts as a model, really. And there are animal models. So for decades now, mouse models engineered of this deletion. So lots of opportunities, zebrafish, lots of opportunities for cellular modeling as well, iPS cells. We're looking forward to even more long-term outcome and management studies that are relevant to adult congenital cardiac disease, and better understanding of the developmental origins of the lifelong pathology and pathogenesis associated with this condition. So I'm just going to end with, a little acknowledgement of our multidisciplinary clinic. We're the best people in the world in our clinic, and also obviously our patients and their families. And I'll stop there.
So thank you very much, Anne, for this outstanding overview of the 22q deletion syndrome. And Anne Bassett and her team and her research students have plowed the field of 22q11 in the last 25 years. And I remember about in the mid-1990s when I was a